Use this to work.
Tēnā koutou katoa. Ko Diana Tawhiti Takuingo. I'm the Head of Department of Public Health. It's my very great pleasure to welcome you all to today's lunchtime seminar and to introduce to you, to those who don't know her, Deborah Woodley, who's the Deputy Director General of Population Health and Prevention at the Ministry of Health. She's been working at the Ministry for, on and off at least, for a long time, what, 25 something years maybe? Give or take. She's had a range of leadership positions over that time, including at one point leading the cancer team. So I got to know Deborah quite well during that period. She also more recently worked at Hutt Valley DHB. And what was your role there? I was Manager Surgical Women's and Children's Health. But she's come back to the Ministry of Health. She came back a year or so ago in her current role, and she's going to talk to us about the future of public health at the Ministry. Thank you, Deborah.
Kia ora, and thank you for that welcome. I put quite a bold title for the presentation, and then I thought, well, I'll see who comes. I'm not sure if my presentation will live up to the title or not, but I'll give it a good go. So thanks very much to Di for inviting me. I agreed to do this, I think, back in February or March. I actually just started the role in February. And you know, when you start a new role, you go, yeah, that's fine. July is miles away. I'll have lots of insights by that time. Needed to say, insights is one thing that you just gather more and more of, and I think probably what I say today I'll think on, and then in a few months' time I'll probably have other things to say as well. But what I wanted to start off by talking about is David Skegg's book. And I thought I'd talk about this because just shortly after I started my role in the Ministry of Health, David Skegg released this book, The Health of the People, and I thought, this is great. I'm going to read it and it's going to have the answers for me. What should we be doing in public health leadership and what should we be doing in the ministry? So I have read the book, and I also went to the launch of the book, and I heard Professor Skegg talk to that. How many people have read the book here? Yep, many people. So you'll be familiar with it, but for those who haven't, I thought I would just give you a bit of a reflection of what I've took from the book. He opens the book by reminding readers about the Havelock North drinking water inquiry, which found that there was a complete failure of leadership and stewardship by the Ministry of Health. And then he continues to outline in the introduction of this book a view that there's an enormous vacuum of leadership in the ministry, and that's just not confined to drinking water. He states that public health generally is compromised by a lack of central leadership and commitment, which helps to explain why the health status of New Zealanders is slipping behind other comparable countries. And he also adds that the Ministry of Health is overwhelmed by the challenge of overseeing personal health services, whilst lip service is paid to the importance of health promotion and disease prevention. Professor Skegg's overall thesis is that we lack central commitment, expertise and leadership, and that public health will be better served if it was the responsibility of a separate entity. So that's quite a challenge, isn't it, as you step into a new role? Also, as part of this critique, Professor Skegg also espoused a view that due to this enormous vacuum of leadership over the last 25 years, we have achieved very little in public health. So I'm not shy about taking challenges on, and I know my team's not. So I took that on, and that's useful to actually take with us. But alongside that challenge, I have been out talking to a number of other people in groups and organisations, which are important as part of our wider stakeholder network. One of the groups that I did talk to were our public health units, and I asked them, so what should we stop doing, what should we start doing, what should we do more of? These are some of the views that they espouse back to me. Now, they're not all of them. I didn't put all of them up because some of them are probably more particular to some more specific things and areas. But they do provide, again, a really good reflection back from public health units about what more they're looking from the Ministry of Health. Some of what they've got up there, you could also argue, is more system level things that we need to work on, but they all sort of do sing out a bit to Ministry of Health needing to take some action. And I think throughout that you can see that leadership is present as an issue, public health voice and policy development is important, effective delivery, rapid action, and I think particularly for me, the last dot point's quite pertinent, which is identifying racism as a determinant of health. So what I'd like to talk to you today about is really to challenge the idea that we've not achieved much in the last 25 years in public health. I want to talk a bit more broadly about the Ministry's role in providing stewardship and leadership, reflect a bit on what that means from a public health perspective within the Ministry, and then I want to use the example of tobacco control to talk about how we can use some of the stewardship and leadership roles and responsibilities and levers to deliver some action in that space. So I've listed here some examples of public health achievements. There are many more, and I've got tobacco control following the slide, but just reflecting on some of the things we have achieved. From a cervical screening perspective, since the program's been up and running, we've had an enormous impact on cervical cancer rates, both mortality and rates of cancer. They've dropped by 50% in New Zealand, and there's been a decline in cervical cancer mortality of 60%. From a breast screening perspective, we set the program up initially in 1998, and then in mid-2004 we had an age range extension. The mortality evaluation that was completed in 2012 found that between 1999 and 2011 there'd been significant reductions in mortality. And in particular, if we keep that coverage rate of 70%, which we're sort of underneath or over or bobbing around that 70%, that equates to a reduction in breast cancer mortality of 30% compared to those not screened. HP vaccination program was launched in 2008, and then of course in January 2017 we extended that to all boys and men up to the age of 26. Since that time, we've had 300,000 New Zealanders vaccinated with HPV. Childhood immunisation, I put that up there. At the moment, we've got a bit of a challenge about declining rates, but I do want to celebrate the fact that for a number of years, we were close to or at 95% coverage of immunisation. And I think what's really important about that particular program is that we managed to do that without having a significant equity gap. And in fact, for Pacific people, their immunisation rate was higher than for other. As I say, we have actually slipped a bit, particularly in the last year, and particularly in relation to Maori in rural areas, and it's something that we do need to be working on. Bowel screening is a particular favourite of mine. I drove the pilot and then the business case for the national program. It was a lot slower than many of us wanted, but it is great now to actually see that we've got a national rollout underway, and we're making a big impact for many of those people at risk of bowel cancer. Just want to talk a bit more detail around tobacco. We've done a lot in the tobacco space. Again, there's a lot more to do, and I'll talk about that later. For year 10s and the ASH results, they claim, I know that my kids who have been through the ASH survey say that, oh mum, you just write down what you think the teacher wants you to say. But regardless of that, we've seen a significant drop in the year 10s who claim to smoke daily. This is a massive drop both for Maori and for non-Maori, non-Pacific. There is still a gap there, but from a decline perspective, that is quite a significant decrease. Overall smoking prevalence is declining. Again, enormous equity gap there, but we have seen for overall a drop from 16.5% to 13.1% over 6 years. And for Maori, the drop has been bigger, still far too big, but we dropped from 38.4% in 2011-12 to 31.2% in 2017-18. This is an interesting slide. This is tobacco consumption. So this is actually how much tobacco is consumed, and significantly greater than our overall decline in smokers. So in the past 8 years, we've actually had a decline of 39% in overall consumption. And then on the legislative front, we've had some wins. In the early 2000s, we had the Smokefree Environments Act changed, where we looked at smoke-free places, smoke-free public places and workplaces. And of course, we also had the standardised packaging regulations go through, and they took effect in April 2018. So we have achieved a lot in public health. There is a lot more to do, especially on the equity front. But I want to address that, and also in particular tobacco more specifically later. Professor Ski focused a lot of his critique in his book on the issue of leadership, stating there was a lack of leadership within the ministry. I would like to think that he wrote that ahead of the appointment of Dr. Ashley Bloomfield as our Director General. But regardless, I do think it's important to focus first on our overall responsibility as stewards and leaders in health before getting more specific to the public health place. So we've been doing a bit of thinking about stewardship within the ministry. So one definition of stewardship is it's the job of supervising or taking care of something, such as an organisation or property. When you take on a leadership role within the ministry, you're very mindful of your role in stewardship. You have a responsibility for the organisation, for its staff. As a public servant, you have a responsibility to ministers. You have a responsibility for the health system and the taxpayers, for their money and the funding that taxpayers provide, and ensuring we get best value out of that. And you also have an overarching responsibility for achieving improved health outcomes for all. Interestingly, in the State Sector Act, the current wording around stewardship is quite internally focused and focused on the organisation. So government department chief executives at the moment very much have a responsibility around the departments, around assets and liabilities and legislation. But I do want to just comment on the free and frank advice comment, because that's quite pertinent to particularly public health space, and also as our role as public servants. I recently attended a forum that Chris Hipkins, who's Minister of State Services, spoke, and he talked very much about the issue of free and frank advice. He emphasised that this was not only incredibly important, an incredibly important role for public servants, but he also challenged us to ensure that we kept doing it over and over again. Sometimes we need to say things to ministers. They may not accept that advice, and they can actually reject our advice and make different decisions. But we never want to be in a position of public servants of not actually telling our ministers things that they need to know. Interestingly, recently the Minister for State Services announced that they're going to be reforming the State Sector Act, and there's going to be a new public services bill. We're looking at strengthening this role of free and frank advice in that bit of legislation. Putting legislation to one side, more broadly, what's our role around stewardship and leadership? Ashley brought these notes to the table one day when our executive leadership team were thinking about that, and we actually all agreed that this is quite a nice way of thinking about our role as stewards and leaders. For me, I think there's some interesting things in there from an overall leadership and stewardship perspective, but what I thought I will pick up on in particular are issues around having a clear plan and having levers and using those levers appropriately to progress action. In terms of overall plan, at a ministry perspective, we have developed 3 outcomes that we want to achieve. These sit within the overall government goal of improving the well-being of New Zealanders and their families. So the 3 outcomes we have, we live longer in good health, we have improved quality of life, and we have health equity for Maori and other groups. And that all links to the overall vision of Paiora, Healthy Futures. The slide's a bit more complex, sorry. Underneath the 3 outcomes, we've got 3 sub-outcomes for each outcome. And interestingly, there are a range of outcomes that directly reflect or support our work in public health. Healthy behaviours, prevention and early intervention, equity, social well-being, socio-economic determinants. And actually, you could probably link most of these, but that's the framing that we've applied to our priorities and our work within the ministry, and that we want to take forward. Alongside that, government, of course, develops its own set of priorities. And I'd like to just share with you what the current system priorities are, which I'm quite excited about. So from a government's perspective, what they want to achieve in health links again to that government goal of improving the well-being of New Zealanders and their families. And then we have, if you drop down to the orange space, we have 3 well-being priorities. We've got child well-being, which reflects this government's work that they've been doing in child wellbeing, partly from the budget and partly from a whole lot of engagement and activity they've been having with communities recently. Mental wellbeing shouldn't be a surprise based on what we've been hearing from government and certainly reflecting the budget package recently. But this last one is one that when I saw it, we got very excited about, wellbeing through prevention. And that can encompass quite a lot of activity. And we're busy trying to populate that, of course, as you would expect. The other 2 that sit underneath it, a strong and equitable public health system, is very much about strengthening not just the infrastructure, but the overall service offering that we have for New Zealanders. And we also want to build a strong primary healthcare system. The thing to point out is equity, and that goes across everything. This government is really committed to equity, ministry is really committed to equity, and I know that my own directorate is really committed to equity. We've recently confirmed a definition of equity. It's up on the Ministry of Health website, and I'll just read you out the definition. In Aotearoa, New Zealand, people have differences in health that are not only avoidable, but unfair and unjust. Equity recognises that different people with different levels of advantage require different approaches and resources to get equitable health outcomes. So that's the definition we've taken on in the ministry that we want to ensure pervades everything we do, and that we challenge ourselves in everything that we do, that we've got that equity focus. So more specifically now, thinking about public health, and I thought I would just talk just for a brief moment about the directorate that I am responsible for. So it's a new directorate called Population Health and Prevention. And for the first time in a large number of years, we've brought together all the different functions of public health back into one directorate. So that means all the work around regulation, legislation, enforcement, alongside all the funding and funding of public health units, funding of our public health services sits within the directorate. We also have screening. We have a number of population health programs such as cancer, all of our long-term condition programs. We have Pacific Health, which I'm really pleased to have. And then we also have a few functions like emergency management. So it's a broad directorate, but it does bring together all the different functions that you'd expect to see, hopefully, in a public health directorate. We've developed these statements around our vision and core purpose. Our vision as a directorate is everyone in Aotearoa experiences optimal health and wellbeing. And then our core purpose is kaitiaki. We work together to achieve health equity and protect, promote and improve the health and wellbeing of people, families and communities. Some of that language reflects the Health Act requirements and expectations around public health, but we also have that link to improvement, partly because we have the whole continuum of diseases such as cancer and diabetes and cardiovascular disease. We also want to really emphasise the importance about family and community, and that we've got to see people in place as well as in their own individual circumstance. So the last bit of my talk, I just wanted to reflect a bit on our work in tobacco control. Earlier on, I had the slides about how we were doing in terms of our outcomes. Everyone, of course, goes back to the issue of Smokefree 2025. How are we going to get there, and how far are we doing? As you can see, we set ourselves mid-term targets when we started off on this journey, so that in 2018, we should be at a population level 10% of smoking across the population, and for Maori down to 19.2, Pacific down to 11.5. We have not achieved that. We've done well in some areas, but we've still got a lot more work to do. And in particular, our record on equity has not been good. And these are just some of the stats more specifically in terms of our Maori rates. And I just want to draw, and I'm going to come back to the issue around our young Maori female rates. They smoke 4 times the rate of non-Maori. If you think back to the slide I had up about stewardship and leadership, there are a number of points that were emphasised. They included components such as developing a clear plan, delivering on our core functions, understanding how we are doing as a system, the role of strong relationships, and ensuring that we use all the levers effectively. Some of these levers include legislation and regulation, funding, setting accountability measures and holding organisations to account, whether that be DHBs, through crowdfunding agreements, or organisations that we contract directly for through contracts. We also have a really important role in setting and clarifying our direction. So on the slide, I've listed a range of areas that we're actively involved in tobacco control space. And I just thought I'll walk through some of those to sort of demonstrate how we're using some of the levers at our disposal. So earlier this year, Minister Jenny Salesa, who's the Minister for Tobacco Control, got agreement from government that we develop a Smokefree 2025 action plan. And I think this is a critical backbone to pull together what we need to do to achieve, or to try and achieve as best as possible, our 2025 goal. At the moment, my team is busy developing a series of policy papers related to the whole tobacco space. And we've had the enormous benefit of having some free and frank public health advice from the coalition, Healthcare Aotearoa Coalition, who've actually provided us with some specific policy advice in this space, which we've been able to reflect in advice taken up to ministers. We know that a lot of the policy that we're putting forward may not be palatable. And that's okay, that's why we're putting up the advice, but we're looking across all the different policy options at this point. Alongside that, our plan will put forward other things that we can do, whether it's around funding services, whether it's about thinking about measures. We're quite thoughtful sessionally about what we can do differently with some of our funding at the moment. We fund directly in the Ministry of Health a lot of contracts. DHBs fund a lot of contracts. Others fund a lot of contracts. There is a view that we've got lots of contracts in place, but they're not aligned. They're quite siloed in the way we approach things, and it's quite hard to measure and monitor effectiveness, because particularly in some DHBs, we've split the providers, you've got no common denominator, and so it's really quite hard to track change. So there are lots of different things we could do without even having some of the policy options that were put forward get across the line. Regardless of that, we are working towards getting an action plan confirmed and out for consultation later this year. So do look out for that and provide feedback, free and frank, welcome. On the legislation and regulations space, we've currently got 2 bits of work underway in this space, which is really exciting. The first one is actually just gone to the select committee. That's around smoking in cars, carrying children. We're prohibiting that, which is absolutely awesome. It's taken years and years to get there, but it's great that we're finally getting that on the road. So feel free to put in a submission to select committee on that bit of legislation. It did get through the first reading in Parliament unanimously, which I thought was really, really good. We're also in the final process of developing a draft bill on vaping and regulating vaping and smokeless tobacco products. As you can expect, this is quite a complex bit of legislation that's being developed, but we're hopeful that that also will get into Parliament within the next couple of months and referred off to select committee. Again, welcome everyone's input into that submission process. Aside from the developing regulation and legislation, we've got a really important role enforcing it. That's both at the ministry and also supporting those in public health units and other places to enforce the existing legislation and regulation. Funding services, I did mention that we do fund quite a lot of services. We have a lot of providers that deliver stop smoking services, but we also have some important national contracts, such as Quitline, and we support the Health Promotion Agency with some of its health promotion work. We also have an important role in setting accountability measures and expectations. We did have for years a range of different smoking targets, but there are other accountability measures that we also look at, both from a contractual perspective, but also at a system level. Having set the measures, it's really important to monitor progress. I've shown you some of that, but actually you can divide and dice the data in all sorts of ways. And a particularly interesting bit of work that we've recently done that I'm going to talk to a bit more is looking at women aged 18 to 24, Maori women 18 to 24, and we use the IDI and we linked a whole lot of data from across different sectors to try and understand the context that these women live in, and it was really interesting in terms of the insights that reflected back. So sometimes it's not just looking at the health data, but the other data that exists across government. There's also an important bit of work that we need to do around service improvement and innovation. People have a variety of views on the ministry's position around vaping, but we believe it's an important cessation tool for those people who smoke. Important emphasis there. And the HPA has recently done a bit of work both on promoting that as a cessation tool and also providing advice and guidance to those wanting to quit. We also, as I talked about, have done some work around improving stop smoking services. And I do want to talk a bit about this. As I talked about, we did look at the challenge of young Maori women. So at the age of 18, 1 in 3 Maori women smoke. At the age of 24, 2 in 3 young Maori women smoke. So within 6 years, you have a rapid increase in uptake of smoking within a small population. We decided as a ministry, let's just focus on this small cohort of our population, first understand what's going on for them and think about what we could do to address the particular issues that arose. So we've been working across the system with providers, with thought leaders, with women who smoke themselves, and a range of other groups. And we started off first trying to understand what the problem was. And we've written that up. It's up on the Ministry of Health website. And that there's a publication called Exploring Why Young Maori Women Smoke. Then we looked at, well, what can we do to address this challenge? And we worked particularly with a small group of providers and young Maori women to try different ways and think about how, what can incentivise women to stop smoking. And it was very much based in a whānau model. It wasn't based necessarily on addressing the smoking as the issue, but more what young women wanted to achieve out of life. And it might have been everything from getting their children into early childhood education. It might have been buying a pair of shoes. it might have been other things. And if you focus on the outcome they're wanting to achieve, then you can start with the family support addressing how quitting smoking can actually help achieve those aims. We've had some fantastic results with that group of women in particular. We've now just finished a process of completing some guidance on how all smoking cessation providers could look at providing their services differently to young Maori women. And I think a lot of this can apply more generically. The guidance was actually developed by young Maori women and the providers themselves. And when it comes out, it will look completely different to the sort of guidance that we've produced before. It's edgy, it's different, it's quite simple, and yet it is really compelling. So that's really neat. The last bit of our project is actually now to work with providers on how they can actually implement the guidance, and we can look at using our funding differently to try and incentivise outcomes. So in effect, what we want to do, if you look at the right-hand side, is we want to shift the focus, definitely from focusing, and I can't even read my thing very well here, but much more of a well-being focus, much more focusing on outcomes, very much thinking about the strengths type of approach rather than the deficit approach. So there are a lot of changes in the way that we want to see our model, and those that work with it see it from a different perspective. So just stepping back from that particular example, I'm keen to apply the type of levers that we've used in the tobacco control space, both to pursue our goal in tobacco, but in other areas of public health. The one that we're particularly putting a bit of focus into at the moment is immunisation, not just because we've got measles outbreaks in the country, but I think it's just such an important platform from which we can improve our childhood outcomes. We've also got Well Child Tamariki Ora review underway, where we want to focus more systematically on how we can improve well child services from a whole of population and life course approach. But just being mindful of all the things that come into our lap from a public health perspective. We could do a lot of work with a lot of people, but unfortunately we always need to prioritise. And there will always be a need to prioritise our effort, and we'll also always need to be thoughtful about what government wants us to work on and how we can progress. There are some areas that will not be priorities for government, so we'll just have to think about what levers we can use to undertake areas and focus in that space. And those that do get a lot of support from government, they're the ones that we're going to put a lot of effort into, and be mindful of our challenge around leadership and stewardship. Just as a final comment and reflecting on Professor Skegg's challenge around a lack of actual leadership, recently Tim Timbensil, who's Associate Professor of Health Policy at Auckland, wrote an interesting article in New Zealand Doctor, and both commenting on Dr. Skegg's book and also a recent article that was in Social Science and Medicine, which looked at the public health agencies across New Zealand, Australia and England. He concluded it might be worth supporting a reinvigorated public health role within the ministry, but he did finish by saying, but no one should underestimate the challenge. Thank you.
Thank you so much, Deb. That was a fantastic talk, and really interesting to get a sense of the overview of your work. We have about 10 minutes for questions, so I'd like to open up the floor. Richard, what would you like to ask about?
I guess it's Richard Edwards from Department of Public Health, Aspire 2025. We've been involved a little bit in the tobacco work over the years, and I'd first of all just acknowledge that the tobacco control team at the ministry and the work they're doing at the moment, and with the strategy and that, which is really quite exciting and extremely welcome. Having said that, over the previous years, we and many others have been arguing for a tobacco control strategy since 2011, and it was recommended in the Maori Affairs Select Committee report, with really precious little success and not a lot of support from the ministry, I would say, about that. So I think we've been quite frustrated over the years about, I guess you might see the passivity of the ministry in the face of political, a difficult political environment, I would completely acknowledge, but maybe not pushing hard enough. And now we've got what's happening now, and that's incredibly welcome, as I said. But I do wonder about, some other areas of public health. If you look at, say, alcohol or diet and sugary drinks taxes, and to what extent is the ministry there showing leadership, again, in a difficult political environment for those issues? So it's great what they're doing where there are opportunities, but what about the areas which are still struggling? Because I think if you talk to alcohol control people, they would probably be equally frustrated as we were a few years ago in tobacco control.
Look, well, thank you first of all for commenting on tobacco control, and I do understand your concerns through the early 2000s, 2011, 12, 13, 14 time around pace, around tobacco. In terms of alcohol and nutrition, that's a difficult one. I see Fran up there and I'm looking at Fran going, Fran, what do I say? But no, we want to take on that challenge. It is a difficult space, particularly alcohol, in terms of how we progress that. From a nutrition space, I can assure you that there are people within the ministry who are speaking up very strongly about doing some things differently. And we've got an opportunity over the next few months to put advice up to ministers on that. We have got a very active Minister for Food Safety. I don't know if you're aware, Damon O'Connor is very active, and in response to that, he's putting up quite a bit of advice at the moment and things that you could do in the food safety system. Now, I know it's only a small part, but there are some things that we can do, certainly around things like added sugars and folic acid and various things like that we could address in some part, support some of the underpinning. More broadly, we've been asked to help support the development of a session with DHB chairs on nutrition and alcohol. So I got a phone call last week, no, it was earlier this week actually, from the chair of the DHB chairs saying, right, the DHB chairs are going to have a 3-hour session on alcohol and nutrition. How can the ministry help us get that session up and running? So this has been, well, we're going to meet next week to have a wee think about, well, how can we do this, to both actually outline this is current policy, there are some innovative things that we are doing, but how can DHB chairs influence their boards about doing something differently within the DHB space? And then from a policy perspective space within the ministry, there are some things that we are doing. There's certainly government support in the school settings, and you'll have seen quite some of that in the budget. More globally, in terms of the impact of obesity and long-term conditions, we've still got some work to do and some thinking. Alcohol is a challenge, and I just want to acknowledge that. We are not progressing much work in that space at the moment, and I think that's something we need to think a bit more about, how we can do something in that space.
Yeah. Bridget, and then there's a question over here.
Hello, Bridget.
Kia ora, kia ora. Bridget Robson from the Irupomere Māori Health Research Centre. It's fantastic seeing the strong focus on equity that the ministry is taking and this current government has, and it's exciting to see the work on young Māori women smoking, which I love the approach that you're taking. The Waitangi Tribunal has come out with some new treaty principles, equity being one of them, but also partnership, active protection and options for kaupapa Māori services. And I was wondering how your directorate might be thinking about incorporating those principles into your everyday work.
I think that's a really good challenge. We have this awesome new Director of Maori Health within the Ministry, John Whanga, whose role is not to do the work, but is to challenge us all to actually lift ourselves across the directorate and support us to think about that. We've initially within our directorate had a couple of workshops around equity, more just focusing on examples of what we are doing, but we want to lift that up into an operating model and a framework of working differently. Hopefully you'll see when the cancer plan comes out, touching wood here, a big theme around equity. That's the biggest thing we can do to improve cancer outcomes, is a focus on equity. Everything we want to do, Ashley has challenged the organisation to have an equity lens around that. I think one of the key things though was good data and good information. So in some areas we've got some really good data and we can actually drill down into understanding what sits behind some of that. I think we've actually got a bit of a challenge around getting some of our insights better understood and reflected, so that instead of just talking about it, we can understand what the issues are. I'm also really keen to think about working differently with Maori, and we're in our well-child tamariki aura space, we're being quite thoughtful about what it means to think differently about well-child services and where the need actually is. At the moment, we've got a model that does well for 70 or 80% of the population, and about 20% of the population are either not engaged at all in well-child services or have pretty intermittent contact. So I think there are opportunities with some of our service development underway to think completely differently, and that's not just about where we get to, but actually how we develop the models from the beginning. Thank you.
Hi Deborah, I'm Anne Fitzpatrick and I'm a researcher here at the university, and I'm also a member of the board of Polio New Zealand. And my question relates to vaccinations and the whole anti-vax movement. It's something that our organisation is very concerned about and wanting to play a part in raising awareness of actually what it means to have polio, because you know, so many young parents nowadays have no knowledge of what polio is and what impact it can have. We are looking at how we get our stories out to young people, to young parents, and wondering whether the ministry sees a role for people who have had diseases that can be prevented through immunisation, conveying their stories, and whether the ministry could see some part in actually helping make that happen.
I think storytelling is really powerful. I think people can understand it a lot more than facts and figures. We're working closely with the Health Promotion Agency on a lot of work on the immunisation space, and actually more generally with Health Promotion Agency in strengthening their role. They would like to be quite a different organisation than what they have been. So I think in the first instance, I can work with you, Anne, on contacting HPA, but we can talk later, because I think there is value in storytelling.
Michael, I'm sorry, this is going to be the last. No, we can't. We've actually got a number of people who are requesting, but Michael was the next one in the queue. Sorry, everybody else.
Thanks, Deborah. It's a great talk, and I thought it was very brave of you to start with David Skegg's book, because obviously that is a very big challenge.
Yep.
Lots of things I'd like to ask you about, such as how academics engage to leave the ministry, and lots of other things. But I guess the topic that perhaps is most current is really the future organisation of the health system, and obviously with the review happening in the background and what it might come up with. I guess that's happening separately to the ministry, isn't it, or in parallel?
Yeah. So that review's definitely independent. The first report comes out in August, or at least it goes to government in August. I'm not sure if it comes out in August, and then it will report back early next year. It's important it's independent so that government consider things separately. We will have a view as an organisation on it. Our view is that regardless, we've got work to get on and do, and whatever the report comes back with, we'll respond at that point. Just in terms of academics though, within my structure, and I know Joe wants me to finish, I've put out a change proposal, and I've really I've put a function in there where we link a lot more with universities, researchers and academics, because I think we can't do it all in the ministry, and we just need to work and embrace the work that's happening out in the university and research field.
I'm going to add to that discussion about, because I've been probably observing the public health system for maybe a bit longer than you, and the two forces seem to be erosion and fragmentation that have been really done a lot of damage. And now, of course, we're in this interesting environment where when we wait for a crisis and then we set up a new independent regulator, we did that with safety in the workplace. There's likelihood of doing that for the drinking water, saying, look, we need a new regulator. There's talk of doing it for cancer control. So I guess it's how do we do this? And most countries looking around the high-income countries seem to, in the end, set up a separate public health agency to manage all of those things that have a habit of going off the tracks occasionally. I'm just wondering, we can't really predict what the inquiry will come up with, but it does seem to be a very common model internationally. So there are some countries you just have to have this large dedicated agency that does regulation to make sure these things work, while your policy function continues to happen in a ministry type setting. I guess we don't know what the future holds.
No, it's going to be an interesting thing to actually see what they come back with. Regardless for me of what they come back with and we end up with, I think the importance is how we work across agencies or across the system. And that is really the end, isn't it? My goodness.
It's not me, I promise. I promise that wasn't me.
Say stop.
I'm just going to say, apparently the microphone's still working. I'd like to thank Deb very much. I'm sure this conversation could have gone on all afternoon. I know that this is actually Deb's day off, and she has an appointment that she has to be getting to, so that's one of the reasons I've been moving things on. I'm sorry for those who didn't get to ask questions. That's it, really. I'm sorry about that. So, but thank you very much, Deb, for coming and speaking to us. That was fantastic. Thank you.
Like funny, wasn't it?